Thank you, Rohit, and thank you for this opportunity. A bit of a repetition. WHO recently came up with two important indicators for cataract and refractive errors. I think what is unique about these indicators is that it kind of defined the intervention threshold, which I think is super critical, not only for defining the denominator, but also to compute how much work needs to be done. Now, otherwise, we just got prevalence data, which basically was a reflection of the work that was not done. And simultaneously, the indicator also built into it the outcome measures. So for the very first time, I think we have this wonderful combination of when to intervene and then what should the outcome be. This together, I think to me is a brilliant move. I think because for the first time, actually we can prevent blindness. Because this advocates that you intervene at an earlier stage. And then this is what I think will be very fundamental to even for IAPP to achieve its 2030 goal of eliminating avoidable blindness. Otherwise, we were focusing all the time on blindness data, and the focus was drawn to dealing with the blindness. That's a kind of no-win game. Why these indicators? I won't go into the depth because Subkota talked about it in great detail. Looking at the current status, again a bit of a repetition. In India, if it comes to cataract surgical coverage, we are at about 36.7% effective coverage. And for refractive error, we don't have India-specific data yet. It's still being computed. Overall, we're at about 35.7% globally. And the goals are a 40 and 30% increase. There was some confusion, but it got clarified. What this really means is that 36.7 has to become 67%. That's an increase, and similarly for refractive error as well. In terms of ground level action, which is the focus of my presentation, we need to recognize that both these conditions, cataract or refractive error, with the exception of maybe myopia control, are neither preventable or self-healing, which means that we have to intervene to make it happen. Which means the entire action has to be at the provider level, whether it is case finding or making or solving this thing. So we essentially need to have two broad buckets of action that we need to engage in. One is to make sure that everyone who can benefit from refractive error correction or a cataract surgery is accessing care, that is active case finding, because not everyone is able to come to one of our facilities. And second is once they come, we make sure that we don't miss diagnosis or in advising, or having a low compliance rate or doing good quality work. So all of that comes into the second bucket, which again is completely at the provider level. Together, this will result in a target achievement. Let me explain this with a simple example. So here we took the data of one hospital for a whole year, which had about 250,000 patient visits. And amongst them, when we applied this WHO criteria of best corrected visual acuity less than 612 due to cataract, 19,000 odd patients were eligible. And then when we looked at our own data, the EMR, which is fairly detailed, we recognized that only 44% of them were actually advised surgery, at least documented. Which means there's an advised gap of 56% as per the data that was available. Of those advised, 5,000 people got operated. Which again means there was a compliance gap of 40%. 40% of them didn't get operated. I'm showing all this to recognize all of these are under our control. Then of those operated, 90% followed up, the reasonable follow-up rate. And then amongst those who followed up, 80% of them achieved the desired outcome, either without correction or with correction. Okay. So when you compute all of this, what it results is then, as providers, we have achieved only a 19% effective intervention rate, different from coverage rate. That is, amongst those who came to us with a problem, we ended up giving only to 19% of them an outcome which meets the WHO goal. Now I just did a what if situation. If we just addressed 50% of the gaps, okay, we had a 56% diagnosis and advice gap. If we're able to address just half of it, then we would have advised 13,700 patients. And with better counseling and empowerment and removing barriers, if you could drive up the compliance from 60% to 80%, then the number of persons getting operated will go up to 11,000. Follow-up rate will not make a big difference, already it's there. And then if you're able to make sure that post-operatively we do good refraction, give glasses to all, we'll end up having about 9,000 odd patients meeting the WHO criteria of outcome, and then that 19% jumps up to 49%. Now, all of these are completely within our control of what we can do. So again, I'm placing before the argument that the opportunity for enhancing the cataract coverage or refractive error coverage rests largely with the providers. Of course, you need enablement from policy, government, some financing, all of those things are there. But ultimately, I think the ball is in our court. And then I also feel that all of us will be interested in this because it achieves the twin goals of altruistic, which is providing eye care to the community, as well as benefiting by it. Because when you intervene early, there's also increased capacity for the patients to pay for the services. So this is going to also result in institutional growth and resources as well. Thank you very much.